Hi, I'm Paul Teirstein, and I'm going to show you a presentation I made at the California Radiological Society meeting. This is a chapter of the American College of Radiology, and the meeting was in February of 2020. Before I spoke, there was a presentation by the American Board of Radiology's president, Dr. Valerie Jackson, and then also by Dr. Howard Fleischman, a representative from the American College of Radiology. Now, when I prepared for this meeting, I was really shocked to learn that in 2018, MOC took the American Board of Radiology's revenue from $4 million to $14 million. And you'll see clear evidence of this. I was stunned by this. This is an enormous conflict of interest. As you'll see, Dr. Jackson, who's the president of the ABR, has a salary of $740,000 a year. And do you think she would get this salary if the ABR only brought in the $4 million from initial certification? Of course not. So Dr. Jackson is a little more than a little bit of self-interest to tell us that we all need to do MOC now when MOC is the basis of her large salary. Dr. Jackson and others from the American Board of Medical Specialties like to use the phrase, "We have the privilege of self-regulation." At this meeting, she warned us that if we didn't enforce MOC ourselves, the government might regulate us. But as I see it, MOC is not self-regulation. It's regulation by the American Board. And as you will see clearly in this presentation, this is more like regulation by the self-interested, where we could use the phrase self-serving regulation. And I want to emphasize that the American Board is a privately owned company. Our government has nothing to do with MOC. All states, in fact, do have ongoing requirements for licensure, and these all take the form of AACME accredited continuing medical education, which is exactly what the NBPAS requires for continuing certification. So here's my presentation. It's about 15 minutes long. Thank you. Thank you for listening. I was asked to give my opinion of MOC. So what I'm going to do is talk about where I think MOC stands today, what's improved about it, and what still needs improvement. These are my disclosures. I'm the president of the National Board of Physicians and Surgeons. This is a competing alternative board. I am unpaid in this role. So I've thought a lot about this, and as I think about it, when we started critiquing MOC about 5 years ago, we had 7 major objections to MOC, and I'm going to go over each one of them very quickly. The first objection, and maybe the most important objection to MOC, is that there is no robust evidence or even a general consensus that MOC improves patient care. In fact, the Vision Commission, which was the ABMS's own commission that was convened to respond to criticism of MOC, the commission's report echoes this by stating there are gaps in the research evidence that demonstrate participation in continuing certification leads to better patient outcomes. I have my own personal suggestion here. I think that we'll never have a level A randomized study on MOC. We're not going to randomize half the doctors to doing MOC and half the doctors to not doing MOC. So my alternative, what I think is a reasonable metric, is that the American Board of Medical Specialty member boards should be able to present an honest survey that shows at least 75% of their diplomates, 1, think MOC helps them become better doctors, and 2, think MOC is worth the time, effort, and money. 75%. That's only a C+. That's all I'm asking. But I don't think it's going to be so easy. If you look at the Vision Commission report, they say right there in the report that only 1 in 10 physicians, 12%, in their survey said that they valued the MOC program. So getting to a 75% level, I don't think will be that easy. Second objection is that MOC is onerous. By that I mean oppressively burdensome and wastes doctors' time. Well, I think the Vision Commission actually was very helpful here because they suggested that we move away from what they call a summative assessment. That's a test that you can get a grade and fail, and move to a formative assessment, which is a test that you're supposed to be able to learn from. And it also should be done longitudinally, that is, over a certain time period. It shouldn't just be one big assessment, high-stakes exam after 5 or 10 years. And in response to the massive anti-MOC sentiment, most of the IBMS member boards have moved from these summative tests to longitudinal formative assessments, which I think are much better. So this is a positive. So I'm going to give a partial check mark here. I think the what's called the OLA, the online longitudinal assessments, I think they are an improvement. MOC is now less onerous, less burdensome, and less wasteful of doctors' time. The problem is we still have no evidence or general feeling that these online assessments make us better doctors. Radiology has just moved to the online assessments, and I've been querying my colleagues in radiology, and most of them say that they're the same old multiple choice questions. Some of them are pretty lousy, and it's not really clear that it makes them a better doctor, although it's easier for them to do. The third objection, all the review courses and time spent preparing for MOC tests increase costs to the physician. Well, this one I think is a solid win. I think this has really been improved. The online assessments are supposed to be testing you on what they call walk-around knowledge you're supposed to know if you're a specialist in your field. So you're not supposed to be able to, not supposed to have to go to a review course or spend time preparing for it. And the tests are very brief. Usually you're only given about a minute to answer the question. So I think this is a definite win and a definite step in the right direction. Okay, the fourth objection was that the multiple choice question tests we take are often out of date, contain errors, and take sides on controversial issues. Now I'm going to give this one a kind of plus minus. Because the test questions are still problematic. And I've asked the radiologists what they think of them, and they tell me that, well, one radiation oncologist, for example, just told me that some of these questions he gets, he just has to guess at the answer because it's not in his field. He's very subspecialized. That's always going to be a problem. And also, it's just hard to write good test questions. So the test questions still aren't very good, but as Dr. Jackson just explained to you, the board is not going to remove your certification if you fail the test. They may give you the question back again, but as long as you're doing the tests and fulfilling the obligations of MOC, you're going to keep your certification. So this is kind of a plus-minus thing. The test questions still are problematic, but since it really doesn't matter if you get them right or wrong, then I'll give it a sort of a half a check mark here. The next major objection is that the required practice improvement projects, so-called PIPs, are onerous and a massive waste of time. In fact, the Vision Commission stated this pretty clearly. They concurred, acknowledging that measuring practice improvement is challenging and that there's some practical and significant difficulty in meeting these requirements. If you look at radiology, if you look at the website, it's very complicated. There's a lot of things you can do to fulfill this requirement. It's going to take you a long time just to figure out what these things are. There's several pages. Here's another page of things you can do. So the response I usually get when I criticize this is they say, well, don't worry about it. You're doing this already. All right, and my response is, please don't tell me I'm doing it already. If I'm already doing it, why do I have to spend time proving it to you? And the truth is that if you're in an academic institution, you're probably on some committees that you can use to fulfill this obligation. So, but if you're in private practice, you might not be. And then you have to sort of make up something. I think this is a waste of time. I think we really haven't figured out a way to do practice improvement in a way that is clearly effective and helpful. So I think they should just eliminate it. It just seems like that's something that would be a real big improvement if they could just eliminate the practice improvement modules. The final two objections, which I think are very important, are that the MOC annual fees are costly and that it's disheartening for physicians to see their boards, once trusted organizations, to so blatantly use MOC as a revenue generator. Now, what I'm going to show you right now is something that I learned just last week, and I was really stunned to see it. And I learned it in a coffee shop, sitting, working on this talk, just Googling publicly available information. All you have to do is is Google American Board of Radiology 990. That's the tax returns. You can find a lot of information out. You'll get something like this, and you'll click on the, say, 2018 Form 990, and you'll see documents like this. So this is the 2018 tax returns from the American Board of Radiology, and their revenue for 2018 was $14 million. As you go through this document, you'll also learn that enrollment in maintenance of certification was approximately 30,000 diplomates. And you'll also learn that the American Board of Radiology certifies about 39,000, almost 40,000 diplomates. So of the nearly 40,000 ABR certified radiologists, 10,000 are grandfathered and do not pay for MOC, while 30,000 pay for MOC. So if you look at the website for the ABR, you'll see that the annual fee for MOC, it's pretty simple. It's only one fee. It's a lot less complicated than internal medicine. It's one fee of $340 a year. And Dr. Jackson just got finished telling you that that's a pretty low fee. It's only 93 cents per day. But when you do the math on this, 30,000 diplomates who do MOC times $340 a year, that's $10.2 million a year. So I call this the toll booth of MOC. And the math I found pretty striking. ABR has 40,000 diplomates. Total revenue in 2018 was $14 million. 30,000 did MOC. 30,000 times 340, as I just showed you, is $10.2 million. So $4 million came from initial certification, $10 million came from MOC. Approximately 25% of the doctors are grandfathers and are exempt from MOC. In 5 to 10 years, when the grandfathers retire, all 40,000 ABR diplomates will do MOC. 40,000 times $340 is $13.6 million from MOC, plus the $4 million from initial certification. So total revenue is soon to be $18 million. So MOC takes the ABR from a $4 million to an $18 million corporation. That's stunning. And still, by the way, there's no real evidence or even a general consensus that MOC improves patient care. This to me is the elephant in the room. We don't want to be impolite this morning and talk about money, but how can the fact that MOC causes ABR's annual revenue to increase from $4 million to $18 million not be part of this conversation? The conflict of interest is just too enormous. As is said, so if you don't know, now you know. I went and looked at what an average radiologist's compensation is in 2019. It was $401,000. Then I looked at what the administrators of the American Board of Radiology make. So Dr. Jackson, who's the CEO, in 2018 made $739,000, almost twice what the average radiologist made. So the CEO of the ABR just told us why she thinks MOC is so important for medicine. And I just showed you how in 2018, MOC took ABR's revenue from $4 million to $14 million. Now, think about this. If ABR's revenue had been confined to the $4 million it receives from initial certification, do you really think its CEO could be paid $739,000? I don't think so. How can someone with such a direct financial interest in MOC be dictating what 40,000 physicians have to do to stay current? This isn't fair and is not right. We often hear we are fortunate to have the privilege of self-regulation, that is, not having the government involved in our certification regulation. Well, I ask, is this really self-regulation, or is it actually self-serving regulation or self-interest regulation by a private, non-governmental company? Now, if you really want to get upset, look at the small print underneath the salaries here. Board policy is to reimburse board members for companions' travel. Gee, I don't get that when I go give a talk. And the board grosses up the reimbursement payments for meals so the board member has no net tax effect. Well, obviously, I could never get away with this, and begs the question, why are physicians held to a more stringent standard than the American Board of Radiology board members? And I've recently learned that this policy has been changed in 2019. So this is no longer a benefit for the board members, and of course that's a positive step. The National Board of Physicians and Surgeons is an alternative board for ongoing certification. The National Board has certified over 8,000 diplomates. There are 119 hospitals that accept the National Board certification for hospital privileges. The administrative tasks are very simple. The application will take you less than 15 minutes to complete. You'll need previous certification by an ABMS or AOA member board. You'll need a valid license to practice medicine. You'll need at least 50 hours of ACCME accredited CME in the past 24 months. And why do we choose this requirement? Because that's what our board thinks is the main way physicians stay current, with accredited CME. And for selected specialties, for the procedural specialties, we require active hospital or outpatient facility privileges in that specialty. And the reason for that is we want to make sure there's some peer review of your procedural volume. And finally, your clinical privileges in a certified specialty must not have been permanently revoked. What more does the ABR require? Well, they require formative tests, which you can fail without losing certification. They also require practice improvement modules that, in my opinion, are either worthless or we already do them, and they require 4 times the annual fees. What more does the National Board require? Well, for procedural specialties, we require active hospital or facility privileges, and we require that your clinical privileges must not have been permanently revoked. So if you got kicked off your medical staff and didn't get reinstated or onto another medical staff, then we will not certify you. And we also require 1/4 of the annual fees of the American Board. The National Board is an alternative certification board intended to provide choice and disrupt the monopoly of the ABMS member boards. The National Board supports initial ABMS member board certification and in fact requires it for continuing National Board certification. The National Board opposes the testing and time-wasting administrative tasks required by MOC and replaces them with ACCME accredited CME. The National Board is a not-for-profit 501c3 organization. Its board members are high-profile thought leaders representing most ABMS and AOA specialties. Our fees are very low. We're only trying to cover our costs. Our annual budget is about $450,000 per year. Physician management and board members are unpaid. Our governance is transparent. We're not-for-profit. We have 2-year board terms, and we have conflict of interest protections. One of our accomplishments was to make our case to the Department of Justice. And in relation to pending legislation, the DOJ wrote an opinion letter on MOC, stating that MOC may have the effect of, quote, harming competition and increasing the cost of healthcare services. They said that ABMS may do so, quote, by imposing overly burdensome conditions on physicians who wish to maintain their certification. So the DOJ opinion letter encourages competition in certification. We all know monopolies increase costs and inefficiencies for all stakeholders. What can you do to help? Well, you can help increase hospital acceptance of NBPAS for admitting privileges. How do you do this? You go to your Medical Executive Committee, the MEC, that's where it happens, and you make the case. You can use the enormous resources we have for you at mbpas.org. You'll find many PowerPoints. You'll find this PowerPoint. You'll find petitions that you can use with your medical staff. You'll find journal clubs. You'll find lots of literature, FAQs. There's a lot of information you can use to go before your MEC and make the case. You should petition your societies like this society, radiology societies. If you're in California, like we are today, the Medical Association and the AMA to support NBPAS. I have to warn you, though, society leaders, I have found, and I've just only learned this from this effort, they're inherently conservative and risk-averse. They don't really like big changes. So the rank-and-file members, like you, must push their leaders. And you can join NBPAS. To join NBPAS, you go to our website, mbpas.org. The application is simple, takes less than 15 minutes to complete. The cost is $169 for 2 years, and then it goes down. So this is our website again, nbpas.org. I encourage you to go to our website, learn more about us. If you're inclined, apply. It's very easy and it'll be very helpful. Thank you for your attention.